Today we're going to review everything you need to know to get started with ultrasound guided IV. This video series is going to be your guide to mastering the Echonos vein system. I'm Matt Wall. I'm a nurse and clinical educator with Echonos, a company that develops intelligent medical tools to empower you, nurses and healthcare providers, to enhance the way that you deliver medical care. It's important to have the right mindset when tackling a new skill. Learning ultrasound guided IV can be challenging, and it's important to give yourself the space to make mistakes in order to improve. I've seen many nurses, me included when I first started, become frustrated after their first few attempts. Expect your first few sticks to be a little rough, and know that it's okay as long as you keep going. It takes about 10 attempts for things to start to click, and around 30 attempts to become proficient. One of my favorite quotes by the great philosopher and fictional character Yoda is, "Do or do not. There is no try. Set your mind to it and you can master this skill." We divided this education into 3 segments. We'll start with some background knowledge and basic terminology. Then we'll jump into the actual technique for ultrasound guided IV placement, and finish up with some common questions, troubleshooting, and a few tips and tricks I've picked up along the way. Let's explore the Echonos vein system. The display will power on in about 30 seconds. When you see the menu, select Vascular Access. Then choose Adult or Pediatric. To enable depths of 4 and 5 centimeters before a scan, tap the 3-dot icon in the upper right corner. Select Enable 4 and 5 centimeter depth. Then select Scan. From the control panel, you can adjust the depth and gain, as well as turn on the center depth markers and needle guidelines. Image quality is optimized when the depth is within the default range of 1 and 3 centimeters. The system defaults to a depth of 2 centimeters and a gain of 1 in adult mode, and to a depth of 1.5 centimeters and a gain of 1 in pediatric. To display the needle guidelines or the center depth markers, tap the icons. The large dots are 1 centimeter apart, and the incremental dots are 2.5 millimeters apart. Then use the gain controls to adjust the brightness. So, to recap, power on the device. Select Vascular Access and choose Adult or Pediatric. Adjust the depth and gain as needed, and use the center depth scale and needle guidelines if desired. How does ultrasound work? Ultrasounds have tiny crystals underneath the surface of the probe that vibrate based on changes in their environment. When electricity passes through the probe, the crystals vibrate and send out ultrasound waves. These waves bounce off tissues in the patient and reflect back to the ultrasound probe at varying frequencies. These waves are converted back to electrical energy based on their frequency, which allows the ultrasound machine to generate an image. Some tissues are better and more reflective than others, which is how we can differentiate the various structures in the body. The ability of these crystals to convert electrical energy to an ultrasound wave is known as the piezoelectric effect. This is when I like to remind everyone that the crystals in an ultrasound probe are delicate and expensive. The Echonos system can handle strenuous use and it's very durable, but a direct impact to the probe could damage the crystals. So just a friendly reminder to handle with care and make sure you place the probe back in the probe holder. As mentioned before, certain tissues are better at reflecting ultrasound waves than others, and this changes their appearance on ultrasound. Bone, for example, is highly reflective and has a bright white appearance. This is also known as being hyperechoic, hyper meaning a lot of bounce back. Tissue, such as muscle, allows some of the ultrasound waves to pass through and some to be reflected. This creates a gray appearance and is known as hypoechoic, hypo for low bounce back. When the tissue reflects a similar amount of ultrasound wave as the surrounding tissue, it is referred to as isoechoic. Lastly, we have no reflection of the ultrasound wave. meaning the wave has completely passed through the tissue. Because there is no bounce back, the image appears very dark, which we refer to as anechoic. So think of air as the enemy of ultrasound, meaning ultrasound can't see through air. And the reverse is also true. Ultrasound sees very well through fluid. This is why a bladder needs to be full when conducting the transabdominal portion of a pelvic ultrasound. A full bladder will push away the bow and the free air, and it actually creates an acoustic window that allows the ultrasound to pass through the bladder and see the organs behind it. So, pop quiz. Would a blood vessel appear highly reflective and bright white, or would it appear dark and minimally reflective? It would actually appear dark and minimally reflective because a blood vessel is full of fluid, or blood, and we know that ultrasound passes freely through fluid. Let's look at how a vein will appear with ultrasound. There are two primary views of the vein. The first is the transverse view, which gives us a circular cross-section of the vein. Using this view for IV placement is considered an out-of-plane approach. The second is the longitudinal view, where we look down the length of the vessel. This view allows for an in-plane approach for IV placement. Both views can be useful when mapping out a vein, but for ultrasound-guided IV placement, we are going to use the transverse view. For most users, the transverse, out-of-plane approach is the desired method because it allows you to pinpoint when you are in the center of the vessel with the needle tip. Next, let's look at how a vein appears with the needle tip. Here we see two different views of the same vessel with the needle inserted. Let's look at the transverse view first. Remember, the transverse view provides a cross-section of the vein. Notice how the hard surface of the needle is hyperechoic, or highly reflective, and appears as a bright white dot on ultrasound. The longitudinal view is our in-plane approach, and the probe is placed in line with the vessel. In this view, we are able to see more of the length of the needle as it's inserted. Again, the preferred view for IV placement is the transverse approach because it allows us to center the needle in the vessel, giving us that bullseye for needle placement. Watch as the needle tip is slowly inserted in a stepwise approach to the vessel. This technique will be further explored in the second video of this series. Alright, so this next point is really important to get right, and it's how you differentiate between a vein and an artery. On an ultrasound machine, they're both going to appear very similar, just these dark circles that you really can't tell apart. And it's really important because it can have dire consequences if you accidentally cannulate an artery. So let's take a look to see how we can tell them apart. Take a look at these two images. One is a vein and one is an artery. But can you tell which is which? The primary way to tell them apart is to complete a compression test. A compression test helps us conduct two important assessments of a blood vessel. It allows us to differentiate between a vein and an artery, and it also helps us detect the presence of a thrombus or blood clot in the vessel. To perform the compression test, simply apply downward pressure on the ultrasound probe and look for pulsation in the vessel. If you detect pulsation, this indicates the vessel is an artery and should not be cannulated. You should also use the compression test to determine if a vein is fully collapsible. When applying downward pressure with the probe on a normal, healthy vein, the vein fully collapses with relatively light pressure. When downward pressure is applied to a vessel with a thrombus, the vessel is not able to fully collapse. Do not cannulate veins that are not fully collapsible. So remember, always complete a compression test prior to cannulation. This will help determine if the vessel is a vein or an artery by assessing pulsation, and it will determine if the vein is fully collapsible, which can help detect the presence of a thrombus. Now, let's compress the first vessel to see if it has any pulsation. Nope, no pulsation, so this vessel is likely not an artery. Now, let's try the second vessel. This vessel has clear pulsation, marking it as an artery, and we won't stick this vessel. Another way to help you differentiate between a vein and an artery is to look for a Mickey Mouse cluster. Yep, Mickey Mouse. So veins and arteries typically cluster in the shape of Mickey Mouse. Here in this image, we can see the two ears, which are usually veins, and the head, which is usually an artery. Now I'm saying usually because you never want to be too sure, and you should always double check yourself by completing the compression test. Be aware, this cluster may not always be in the upright orientation, so look for it in different positions and sizes. Now let's look at a real-life example of a Mickey Mouse cluster. Again, here we can see two ears, which should be veins, and the head, which should be the artery. Let's do a compression test to check if we are correct. We can see the two ears collapse easily and don't pulsate. With even more pressure, we can compress the center vessel and see that it pulsates, which indicates it's an artery. I would not recommend cannulating these veins until you are at least very experienced or after consulting a physician, and it's best to just avoid them altogether. Understanding some basic tissue anatomy can help you anticipate the type of vein or vein and artery cluster you might encounter. The top layer of tissue includes the epidermis, dermis, as well as subcutaneous fat. The bottom layer is referred to as the hypodermis and is where you will find muscle tissue. These two layers are separated by a thin layer of tissue known as the fascia. Here we can see the fascia layer highlighted in orange on the two ultrasound images. Blood vessels located in or above the fascial layer are considered superficial. These superficial vessels are ideal for cannulation as they are typically not clustered with an artery, as seen here with the vessel on the right. Vessels located in the hypodermis layer are considered deep. It is in this layer that you will see Mickey Mouse clusters, which are not ideal for cannulation. As you are scanning, try to cannulate superficial veins that are in or above the fascial layer. So remember, compress to assess. Every vessel you cannulate should be compressed to see if it pulsates. If it pulsates, don't stick it because it's an artery. If it's easily collapsible, then it's a vein, and that one's okay. Now I will issue you a word of warning. If your patient has a low blood pressure, which is often common in septic patients, you may not notice the pulsation as easily, and this is also similar in patients that are very bradycardic. There are a few more things you might run across as you're scanning patients that are important to recognize. The first of these are valves. These are better visualized in the longitudinal view, and you may notice dilation around the valve. Do not access near a valve as it may interfere with advancing the catheter. A confluence occurs when two veins join together in their journey back to the heart. This can be seen in either the transverse or longitudinal views. You may have also heard the term bifurcation, but this term is reserved for arteries as they split or bifurcate when traveling away from the heart. Let's watch as these two veins form a confluence in the transverse view. Nerve bundles typically appear as small honeycomb-like structures. Accidental cannulation of a nerve, although unlikely, can be painful for the patient and potentially cause permanent nerve damage. Notify a provider immediately if this occurs. The primary nerves of the upper extremity include the medial, radial, and ulnar nerves. They can be very tricky to spot, as we can see here in this image. You might also see a thrombus or a blood clot in a vessel. These typically appear as gray hypoechoic structures that partially occlude the vessel. Again, avoid these and notify a provider if found. So how do we know where to look for a good vessel? And what vessels are we looking at anyway? I really recommend that you practice scanning so you can get a sense of where these vessels are. Just like in traditional IV placement, you should avoid the joints, so the elbow and the wrist, and you should always map out your vessel to make sure it's straight and healthy and round. Now, a great place to start is the cephalic vein. Make a C for cephalic with your hand, and from the center of the C, follow that back to your mid-forearm, and you should be very close to the cephalic vein. Always use good clinical judgment when selecting a vessel. The vessels above the antecubital region should be avoided and reserved for life-threatening emergencies and after consulting a physician. These vessels should be reserved for patients that might need central line access, especially in patients that are going to be admitted or for renal patients that might need hemodialysis. To gain some familiarity with vessels in the upper extremity, position your arm with the thumbs up. An easy way to remember this is you're giving the thumbs up for the cephalic vein because it's a great vessel to stick. The cephalic vein runs along the top thumb side of your arm. The basilic vein runs along the base of the arm and is also a good vessel for IV placement. Be aware of the deeper brachial vein that typically runs between the basilic and cephalic veins, as it's associated with a higher rate of DVT or deep vein thrombosis with central line catheters. Just remember, hit the brakes for brachial and avoid this vessel. As you are scanning, you may see distortions in the image which we call artifact. There are common artifacts you might encounter, and recognizing them can prevent you from being distracted by them. The first is known as reverberation artifact. This occurs when a highly reflective surface, such as those found on a needle, cause the ultrasound wave to immediately bounce back and forth or reverberate, creating a comet tail appearance. This may indicate the probe is positioned over the shaft of the needle and not the needle tip. On rounded structures, such as veins and arteries, the ultrasound beam is slightly refracted or altered and may give the appearance of two dark lines on either side of the vessel. This is referred to as edge artifact. In these images, we see examples of artifact that make the area behind a structure appear either dark or light. In the first image, depicting shadowing, we see the highly reflective surface of a bone. The bone fully reflects the ultrasound beam, causing the area behind the bone to become dark or shadowed. Fluid-filled, cystic structures have the opposite effect and will enhance or artificially brighten aspects of the ultrasound image. This effect is seen here in the second image showing a blood vessel. The ultrasound wave is able to pass through the fluid of the blood vessel more quickly than it does in the surrounding tissue, causing this false brightness to occur behind the vessel. This can actually be a helpful sign when differentiating fluid-containing versus non-fluid-containing structures. Only fluid-containing structures will have this enhancement artifact. Although not a type of artifact, this is something that can affect the quality of your ultrasound image. Angling the probe causes some of the ultrasound waves to bounce away, as can be seen in the red arrows on this image. This reduces image sharpness. Simply hold your probe upright, and this is an easy fix, allowing for the maximum amount of reflection to the probe. Now, let's explore the types of probes you might come across. There are three primary types of probes for ultrasound imaging, and each has a different use based on their footprint. The curvilinear probe provides us with a wide-angle view and is typically used for abdominal imaging. It is the desired probe for bladder scanning, as can be seen in the Echonos bladder system. A phased array probe provides a square or rectangular footprint. The Echonos Cosmos system uses a phased array probe and delivers diagnostic-grade imaging of the cardiothoracic and abdominal regions. Finally, we have a linear probe, which is perfect for assessing vessels and soft tissue. A linear probe is what we will be using on the Echonos vein system. So let's take a look at the linear probe. So the linear probe has a dot or probe marker on the side here. And this dot should always match up with this dot on the screen. So left side of the probe is the dot or probe marker, and left side of the screen is the marker on the screen. Left and left. They should always match. If you accidentally flip it, you'll end up getting a mirror image, which you will probably do at some point. You're going to be really confused. So just always remember to flip it back so that way the two probe markers match. It's important to apply a probe cover for infection prevention purposes. The type of probe cover will depend on what is available in your clinical setting. Best practice would be a sterile cover designed specifically for ultrasound probes, as seen in this image. I've also seen institutions use Tegaderm as a probe cover. You will need to apply a small amount of gel under the probe cover to prevent air from getting in the way of the image. Similar to probe covers, there are also many types of ultrasound gel. The priority is again differentiating sterile versus non-sterile. Many of you will encounter a large bottle of gel on your unit. This is intended for assessment only. It is typically used between patients and raises infection prevention concerns. It is best to use the individualized packets that can be one patient use only. Careful thought should go into selecting the appropriate catheter for IV placement. This is specifically important for larger vascular devices such as PICCs and central lines. Vascular access nurses will consider the patient's age and comorbidities, as well as the intended treatment, duration of therapy, and vascular characteristics. But a general rule of thumb is to select the smallest gauge that is appropriate for the intended therapy. According to the Infusion Nursing Society's standards of practice, a vascular device such as an IV should not exceed 45% of the vessel diameter, and it's general practice to try not to exceed 33% or a third of the vessel. A quick visualization shows that a third of a vessel would be quite a large catheter, which is why when dealing with peripheral IV selection, this isn't usually a problem unless you are dealing with very small vessels or the pediatric population. With that said, the Echonos vein system does allow for easy measurement of your vessel if determining the catheter to vessel ratio is necessary. To measure the vessel, tap Stop, then the caliper icon, then the word caliper. Move the measurement point to one side of the vessel, then move the second measurement point to the other side and note the diameter. Selecting a catheter of the appropriate length will also help with your success in IV placement. Students tend to gravitate to the more traditional length, 32 millimeters. This can actually be a source of error as you will find you run out of needle before you reach the vessel. Typically, ultrasound-guided IVs should be attempted with longer needles in the 45 to 48 millimeter range, unless the vessel is very shallow. Great job making it through this first video. In the second video, we're going to go through the actual technique of ultrasound-guided IV placement.